Hi, I'm Dr. Rebecca Bernard, and thank you for joining me for a discussion of patients at risk, the rise of the nurse practitioner and physician assistant in healthcare. This content is based on my upcoming book, co-written with Nuran Al-Ajba, that is being published by Universal Publishers. Please feel free to contact me at any time through my website. I'm also a board member of Physicians for Patient Protection, an advocacy group made up of physicians with a mission to ensure physician-led care for all patients and to advocate for truth and transparency regarding healthcare practitioners. I'd like to introduce you to a young woman by the name of Alexus Ochoa. Alexus was just 19 years old and she was in excellent health when one day she suddenly developed acute symptoms of shortness of breath, chest pain, and fainting. An ambulance took her from her dorm room to Mercy El Reno Hospital. When she arrived there, she was quite ill. Her vital signs were unstable, and she reported no medical history and that she was only taking birth control pills. Alexus was met at the emergency department by a family nurse practitioner, Antoinette Thompson. Thompson was an experienced nurse. She had worked first as a firefighter paramedic and then as a nurse in the emergency room before she returned to school to get her master's degree as a nurse practitioner online from the University of South Alabama. During her program, she gained her clinical experience working in a county health department providing prenatal care to low-risk women. She had been a nurse practitioner for about 8 months when she began to treat patient Alexus Ochoa. Of note, Ms. Thompson was working by herself in the emergency department without any on-site supervising physician, and there were no physicians in-house at the time that Alexus Ochoa was seen. Antoinette Thompson was hired by the organization Mercy Health Systems, which was a multi-billion-dollar organization that owned and operated hundreds of facilities across the South. They hired and credentialed Antoinette Thompson as a family nurse practitioner to work in an acute care role, which contradicted the Oklahoma Nurse Practice Act, which required that only nurse practitioners with acute care training should be working in that type of setting. They also allowed nurse practitioners to staff the emergency room without on-site physician supervision. However, even though this was the case, the organization advertised on their website that physicians were always staffing the emergency room. In fact, they stated, "Our ED is staffed round the clock with a team of highly trained emergency physicians," and again that they offered quick access to physicians. Unfortunately, this was not the case when Alexus Ochoa came into the emergency department. Unfortunately, there were a variety of errors that occurred in the evaluation of Alexus Ochoa by nurse practitioner Thompson. The first problem that happened was that Alexus fainted while she was in the bathroom giving a urine sample, which caused the nurse practitioner to stop focusing on her symptoms of shortness of breath and chest pain and start worrying about maybe something being wrong with the girl's brain and ordering a CAT scan of her head instead. And in fact, the nurse practitioner canceled the original order that she had made for a CT scan of the girl's chest, which would have shown that she was suffering from a pulmonary embolism or blood clot in the lungs. The second error that happened was that a lab report came back showing that Alexus had methamphetamine in her urine, although it was clearly a lab error because the test showed negative amphetamines, which is the breakdown product of methamphetamine. And additionally, Alexus had no clinical signs or symptoms to suggest methamphetamine toxicity, and she also adamantly denied the use of drugs. Particularly, this should have been considered valid because Alexus was a straight-A student and an athlete. However, the nurse practitioner, once she saw that lab result, she began to treat the patient as if she were a drug addict and suffering from drug toxicity. Alexus was treated for over 11 hours by Thompson, who never once contacted a supervising physician. She did reach out to a consulting physician, a cardiologist at a larger facility nearby. However, she never actually called the physician who was supposed to be in charge of supervising her. After 11 hours of futile treatment, she finally did transfer Alexus to a tertiary center. She was diagnosed and began treatment for her bilateral pulmonary embolus. However, it was too late and Alexus passed away. Alexus Ochoa's family did sue Mercy Health Systems, and they won a over $6 million verdict. Right after this happened, Antoinette Thompson moved away from Oklahoma and took a position in Iowa. According to their website, she currently practices at the Veterans Memorial Hospital in Iowa. The Veterans Administration is an independent practice site across the country, and so is Iowa, which would indicate that she theoretically could be caring for patients independently without physician supervision. Interestingly, it took 5 years from the death of Alexus Ochoa before any action was taken against Antoinette Thompson for her role in the death of the patient. She was finally sanctioned just recently, a few months ago, and she faced a 1-year suspension in the state of Oklahoma, a $1,000 fine, and some requirements for continuing education. So, of course, all of this begs the question of how did we get to this place in which nurse practitioners are able to independently treat patients that are acutely ill, like Alexus Ochoa. We'll review some of the history of nurse practitioners. First, the history of nursing in the United States began in 1872 when a physician, Susan Demock, started the first U.S. training program for nurses. What's interesting about Dr. Demock is that she had applied to Harvard Medical School, but she was rejected because the school would not accept women. She then went over to Switzerland, where she graduated from the University of Zurich with high honors and returned and focused on teaching nurses. The nursing profession rapidly expanded into the 1900s, especially as the number of hospitals rapidly increased. And in the 1950s, nurse education moved from hospitals and into universities. The first nurse practitioner program was founded by Henry Silver, a pediatrician, and Loretta Ford, a nurse. And the program was focused on creating pediatric nurse practitioners that would provide well child care, following protocols and working side by side with physicians. Within just less than 10 years from one program, there were 65 nurse practitioner programs across the country. And of course, now today we have more than 400 nurse practitioner programs. In the 1970s, the government created a committee to study an extended role for nurses, and this had a lot to do with a predicted physician shortage. And the government further incentivized nurse practitioners by providing mandates for rural health care to be provided by nurse practitioners. The Rural Health Care Act, in fact, to this day, mandates that at least 50% of the healthcare clinicians providing care in rural healthcare clinics that receive federal funds must be nurse practitioners or physician assistants. In the 80s, nurse practitioners gained provider status, which meant that they could be paid directly for their services rather than working through a connection with a doctor or a hospital. And in 1996, they gained direct payment from Medicare. The 1980s and 90s was the beginning of the effort to achieve full practice authority, starting out in the states with larger rural areas, but then rapidly expanding to other states. The most current map of nurse practitioner independence is here. It's not quite accurate, of course, because you see here in red, California, the assembly just passed nurse practitioner independence. It's waiting on a signature from the governor there. Florida, I've crossed out because there was a law allowing primary care nurse practitioners to practice independently, and that's something that they're still trying to work out. But here, everything in green allows nurse practitioners complete independence, and also that includes the Veterans Administration, and then red is restricted practice. Why have we seen such an increase in nurse practitioners? Well, of course, there have been very coordinated efforts by nurse practitioner leaders to increase the numbers of nurse practitioners, and they really received a big push for this in 2010 when the Institute of Medicine created a report called the Future of Nursing Report. And that report made several recommendations, including increasing the number of nurses with a doctorate degree and calling for nurse practitioners to be in full partnership with physicians. That same year, the Affordable Care Act expanded nurse practitioner training and created a nurse-led community health center model to expand the role of nurse practitioners. That 2010 law that increased funding to nurse practitioner programs really increased the number of graduates from nurse practitioner programs. The number of programs rapidly increased, and actually there has been a doubling of nurse practitioners between the years of 2010 and 2020. Nurse practitioners worked very hard to achieve this rapid increase. They did it by cooperating. They worked together. Back in 1993, nurse practitioner leaders from 13 different organizations came together for a summit, and they created a coalition. And through that coalition, they worked to advocate politically and to explain to politicians and lawmakers the role of the nurse practitioner, and to convince them that nurse practitioners could take on many of the roles that physicians typically did. And also they would tell lawmakers that they could do this type of job in a more cost-effective way than physicians. They were helped by funding from organizations like the Carnegie Foundation, but also the Robert Wood Johnson Foundation. It's important to talk for a few minutes about Robert Wood Johnson because this organization has donated so much money to advance the practice of nursing in the United States. Robert Wood Johnson Foundation was founded by Robert Wood Johnson, who was the creator of Johnson & Johnson, one of the world's largest manufacturers of household items and medications. The foundation is the largest health-focused philanthropy in the U.S. with over $11 billion in assets, and they've contributed a sizable amount of money to promote the work of nurses. One of their most important efforts was to create executive nurse health fellowships, to which they've donated over $41 million over the last 20 years. And the idea of these fellowships is to help place nurses in positions in which they will be closely related with politicians, lawmakers, different organizations that are working to write healthcare law and policy. And it's been very successful. They've placed many nurses in high positions of power in local, state, and federal positions, and have gotten nurses on many important payment committees and different areas where they were able to influence healthcare policy. The Robert Wood Johnson also subsidized the Future of Nursing report that I mentioned, and then they also donated millions of dollars to the AARP in order to implement recommendations from that report. They also donate millions of dollars to media sites like National Public Radio to promote healthcare reporting. They call it New Avenues of Healthcare Reporting. So often you'll hear very favorable reports about nurses and nurse practitioners in many different media organizations, and sometimes you'll find that they're being funded by Robert Wood Johnson. So Robert Wood Johnson Foundation has relationships, of course, with Johnson & Johnson, which is the main organization, and they have a subsidiary, which is Janssen Pharmaceuticals, which makes many common medications, including opiates. They have a relationship with CVS, and of course we know that CVS owns many Minute clinics, which are small health clinics within the drugstore, and they're almost universally staffed by nurse practitioners alone. And they make a lot of money off of the care provided by nurse practitioners. And then, of course, patients that are being seen there are filling their prescription right there at CVS, and maybe the prescription is even for a medication produced by Janssen or Johnson & Johnson. There's also a relationship with the AARP, which is a little bit unclear, but the AARP receives a lot of money from United Healthcare because they act as sort of an intermediary, encouraging seniors to buy supplemental Medicare plans. And United Healthcare owns Optum Rx, which is a large pharmacy benefit manager. So it's unclear exactly what all of these relationships are, but you can see that there is a link between medications and household products, drugstores, and prescribers. Let's take a second and review another type of practitioner that has some similarities to nurse practitioners, and that's physician assistants. Interestingly, the profession started around the same time. The first physician assistant program opened in 1965, and it was created by a physician also, Eugene Sneed at Duke. And Dr. Sneed had the idea of taking military medics who were returning home from the Vietnam War and taking advantage of the experience that they had gained during wartime and giving them some extra education so that they could work in primary care. Henry Silver, a few years later, the same physician who started the first nurse practitioner program, created a physician assistant program at the University of Colorado, but he called his graduates child care associates. And again, the idea was that these individuals would work very closely with physicians. Because of the predicted physician shortage in the 1970s, there was federal funding to try to train physician assistants to work in primary care and in other underserved areas. Now, unlike nurse practitioners, physician assistants really have not consolidated to the same degree and fought as much for independent practice until the last few years. Now we're seeing somewhat of a swing in the pendulum, and we're seeing some type of a separation where physician assistants want to be recognized as independent medical providers. In fact, to the point where they've actually tried to change their name, and rather than being called physician assistant, they want to be called just PA. And they have even a marketing campaign towards patients that's called Just Say PA, and also one that's called Your PA Can, or Your PA Can Handle It. The idea being that they want to explain that they are separate from physicians, that they can also provide care. And you know, part of that has to do with the competitive advantages that nurse practitioners have in being permitted to practice independently. Many employers are preferentially hiring nurse practitioners over physician assistants because of the supervision requirements. The other effort that physician assistants have made is to shift away from a direct relationship with one physician and change to something they call optimum team practice, which would allow them to be associated more loosely with either a hospital or an organization or a theoretical group of physicians that they would potentially collaborate with, but not necessarily being responsible or under the supervision of one physician. And they've been successful in one state so far where they've won independent practice, but they are fighting for independent practice in other states, and they did gain some temporary expanded practice rights in several states because of COVID-19. Like nurse practitioners, physician assistants have also grown rapidly, not to the same degree, but they've increased by about 60% between 2010 and 2020. There is no requirement for a residency program for nurse practitioners. Physician assistants usually receive a 4-year bachelor's degree, undergraduate degree, and then the PA program is 2 to 2.5 years, and again, no residency is required. There are two types of physicians: DOs, or doctors of osteopathic medicine, and MDs, medical doctors. They have a 4-year undergraduate degree, typically complete a 4-year doctoral program, which is medical school, and then there is an absolute requirement for residency training. A few states allow 1 or 2 years before a medical license is granted, but anyone that attended medical school outside of the U.S. is required to complete at least 3 years of residency before receiving a medical license, and many states have that minimum of 3 years. If we look at this in terms of hours, you see that nurse practitioner programs require 500 to 1,500 clinical hours. For a master's degree, the minimum is 500 hours. For a nurse practitioner, it's usually 1,000 additional hours. Physician assistants receive about 2,000 clinical hours in training, and physicians are estimated to complete 15,000 hours by the time they finish their residency program. Just for the sake of comparison, let's take a look at some different occupations and what the minimum requirements are. Here you'll see that a barber is required to have completed 1,800 clinical hours or barbering hours, a cosmetologist 1,500 hours, a massage therapist 750 hours, and a makeup artist 600 hours of practice doing makeup before being permitted to be licensed. Even Petsco dogs groomers are required to complete 800 hours of training before they are permitted to groom dogs independently. Why is all of this training important? Well, studies have consistently shown that it takes about 10,000 hours to gain mastery in any subject. And if you don't get that experience, then you fall victim to a phenomenon called Dunning-Kruger effect. This is a psychological phenomenon that was described by psychologists David Dunning and Justin Kruger. And what they showed was that often people have a misunderstanding of their own knowledge about a subject, and they tend to rate themselves as knowing more about a subject even when they really have little experience or true knowledge about it. And they've shown this in this graph, in which people that have very little experience often rate their own confidence of their knowledge about that subject as being extremely high, sometimes even approaching 100%. Then, as the learner begins to learn more, gain experience, they actually show a decrease in their level of confidence. We see this a lot in physicians that are going through training. Sometimes we experience what we call imposter syndrome, in which we start to really feel like we really don't know anything. And that's as we gain more experience, we realize how much there still is that we don't know, and we have a drop in our self-confidence. But then that level of confidence slowly begins to increase as we gain more and more experience. And then as we gain an expert level of understanding, we usually have a fairly high level of confidence in ourselves. Although it's interesting to see that we usually don't approach that same high level of confidence that we may have when we really know very little about a subject. And that's very dangerous because sometimes people don't know what they don't know, and they can make mistakes that can harm patients. And it's especially dangerous when someone without adequate levels of training and education wants to care for patients independently without any supervision from someone who may be more knowledgeable about the subject. And this is really the crux of something called full practice authority, in which nurse practitioner leaders have called for the opportunity for nurse practitioners to have the right to evaluate patients, diagnose, order, and interpret diagnostic tests, and initiate and manage treatments, including prescription medications, under the exclusive license authority of the State Board of Nursing and without being supervised by a physician. If you look on the American Association of Nurse Practitioners website, you'll see that they promote full practice authority by saying that allowing nurse practitioners to have this independence, it will increase access to patients, especially in underserved areas, that it will streamline care, it will allow patients a choice, and they say that it will actually decrease costs. So are these facts true? First of all, nurse practitioners do not work in rural areas at any greater extent than physicians. 77% of all nurse practitioners practice in cities and suburbs, and less than a quarter practice in rural areas. And in fact, states that have granted independent practice to nurse practitioners have not seen the promised increase of nurse practitioners into rural areas. And efforts to increase nurse practitioners into these areas has not been successful. A 2012 pilot program granted $179 million to try to increase nurse practitioners into rural areas. At the end of the pilot program, only 9% of participants entered rural care, 20% worked in underserved areas, and just 12% of these nurse practitioners worked in primary care. And this is actually something we're seeing throughout nurse practitioner practice. There's been a decrease of nurse practitioners entering into primary care by 40% since 2004. To really see where nurse practitioners and physicians work, you can take a look at the American Medical Association state maps. And here's an example. I picked Washington State because it does have a large rural area and because it was one of the first states to grant independent nurse practitioner practice. You can see here that primary care physicians are represented by a purple dot and nurse practitioners by a blue triangle, and there's a significant overlap amongst practices. But actually what has been found, and this is true across the United States, is that family physicians are the medical professional that are most likely to work in rural areas. Let's look at some of the data that nurse practitioner leaders have used to advocate for independent practice. One of the common phrases that you'll hear from advocates is that 5 decades of research have shown that nurse practitioners are able to practice safely and effectively. So is that true? And let's break down and look at some of the studies that nurse practitioner leaders have used to advocate for independent practice. Probably the most important review of data has been performed by Cochrane, which is an organization that advocates for evidence-based practice. They released a study that they called Nurses as Substitutes for Doctors in Primary Care, and their conclusion was that for some ongoing and urgent physical complaints and for chronic conditions, trained nurses probably provide equal or possibly even better quality of care compared to primary care doctors and probably achieve equal or better health outcomes for patients. So that's pretty compelling, and if you just read that at face value, you would say, yes, nurse practitioners can do the same thing as physicians. But what does the study really show, and what were the actual parameters that were reviewed in these studies. The single best study in the United States included in the Cochrane Review was completed by Hemani in 1999. Importantly, this study was 100% supervised, the same for really every single study that was included in the Cochrane database. The truth is that there really are no well-done studies that compare independently practicing nurse practitioners to physicians. And of course, here in this study that was completed at the Veterans Administration involving 450 patients, all nurse practitioners were being supervised by a physician, and physicians did sign off on their charts, which means that if an error or a medical problem was determined to be done by an attending physician, then there was an opportunity for correction and changes to be made to the treatment plan. The conclusion to this study was that in a primary care setting, nurse practitioners may utilize more healthcare resources than physicians. And that meant that nurse practitioners utilized more healthcare resources than medical residents as well as physicians. They ordered more lab tests, they ordered more imaging studies, and that their hospitalization rates were the highest, even though they were not caring for the sickest patients. The second study conducted in the United States was done by Mundinger in 2000, and this study has been cited more than 100 times in the literature. It compared 17 physicians to 7 nurse practitioners in community outpatient primary care clinics. It monitored 1,300 patients. They were predominantly low-income, transient Hispanic women that went back and forth between New York and the Dominican Republic, and the study only followed them for 6 months. Physicians were always available for consultation, consistent with New York law at the time. The study found that there were no differences in health status or health service utilization, but that nurses provided more education. They also ordered more laboratory tests, and they more frequently measured the height of patients. What's really important about this study is, first of all, it was very short, only 6 months. Patients were really low risk, so it would have required a much larger sample size to actually see any serious differences in outcomes. But more importantly, the critique by Cochrane was that this study had the highest bias of all 18 studies that they reviewed, in that subjects were not randomized, there was no blinding done, and that the study authors reported only favorable data. The third study in the United States that was reviewed by Cochrane was completed by Lewis in 1967. It followed just 66 patients, and it was really only designed to ask whether or not patients would be accepting of seeing a nurse practitioner, and did not really monitor outcomes. After the United States, the most studies were done in the United Kingdom. 2 of the studies there involved telephone triage using nurse practitioners or advanced nurses, and it found that nurses could safely provide telephone triage advice by using a software program guide, and that telephone triage did reduce the workload of face-to-face visits for physicians without any increase in adverse outcomes. However, this was not found to save time or money. Schum in 2000 evaluated 790 low-risk patients evaluating minor medical complaints. Any high-risk patients were excluded, and nurse practitioners were 100% supervised by physicians. Of these low-risk patients, more than a quarter required evaluation by a physician, and ultimately researchers were unable to draw any conclusion about the safety of nurse-led care because the study group was not large enough. Venning in 2000 evaluated 1,300 patients at a walk-in clinic over 2 weeks. This was a 100% supervised studies, as physicians were always available, and patients did require the direct assistance of physicians 17% of the time. The study was designed specifically to evaluate the cost effectiveness of nurse practitioners, and found that NPs spent more time with patients, performed more tests, and had more follow-up visits. However, it was inadequately powered to determine whether or not nurse practitioners were cost-effective in primary care. Moher in 2001 designed a study to assess the prevention of heart attacks and strokes by following several risk factors. This was 100% supervised and followed a protocol, and found that the care was equally effective. However, following up on these 3 risk factors did not lead to fewer heart attacks or strokes. There were several studies performed in specialty care. Larson in 2014 evaluated patients in a rheumatology clinic. This was 100% supervised, and found that nurse-led care in protocol-driven chronic disease was cost effective and did not affect quality of life care. Chan in 2012 had a study of GI patients. It evaluated patients that had had an endoscopy already and had dyspepsia, excluded any high-risk patients, and found that nurse practitioners could provide cost-effective care following up under these specific parameters following endoscopy. The Netherlands had several studies that were included in the Cochrane database. Derek Van Deel, 2009, was a first contact primary care study. However, the conclusion was that it was inadequately powered to determine the safety of nurse practitioners. Howling in 2011 followed non-insulin requiring diabetic patients, 100% supervised, again, inadequate patient sample to assess quality of care, and did find that nurse practitioners referred more often and spent longer with patients. Voet Pruis in 2010 evaluated patients at risk for coronary artery disease, excluded high-risk patients, and they did find that nurse practitioner patients had an increased risk reduction when they followed physician-created disease protocols. Canada had several very important studies. Most importantly was Spitzer in 1974. This was an excellent, groundbreaking study on nurse practitioner use. It was 100% supervised because 2 physicians and 2 nurse practitioners worked side by side in the same clinic. They only followed low-risk patients, and the study found that nurse practitioners could be as safe and effective as a physician 55 to 67% of the time. And again, that was when they were 100% supervised. Chambers in 1978, another 100% supervised study, found no differences in patient outcomes when receiving first contact care from a physician-supervised family practice nurse versus care provided by a physician. Several other studies, South Africa showed that nurses could monitor HIV therapy following protocols, again 100% supervised. A study in Sweden, nurses were able to safely monitor patients with stable inflammatory arthritis, 100% supervised. Iglesias, a study in Spain, evaluated patients with burns, injuries, diarrhea, low back pain, cold symptoms, and pain with urination, excluded high-risk patients, and was 100% supervised. They found that nurse practitioners did a good job at managing burns, injuries, and diarrhea. However, they were only able to independently manage a fraction of low back pain, colds, and urinary symptoms independently without physician involvement. So the bottom line is, although if you just read the headline of the Cochrane database, it sounds like nurse practitioners can really replace physicians. But the bottom line is that there have been no studies that have actually shown that nurse practitioners can do the same job as physicians when they're practicing independently, and also when they're caring for patients that are high risk or complicated. Limitations of all of the studies that were evaluated included small sample size, non-diverse patient populations, and really short levels of follow-up. However, it is important to note that these studies did show that nurse practitioners and physicians working closely together can provide excellent quality of care to patients. I think it's good to take a look also at the VA because the VA did grant independent practice across the whole country. But what's interesting is that they released an evidence summary in 2014, and the headline said that there was no difference in care provided by nurse practitioners and physicians for health status, for quality of life, mortality, etc. But if you look over here at the strength of evidence, you see that the evidence was either insufficient to low, at best medium, and that many of these studies that were evaluated had a high risk of bias. So the VA decided to grant independent practice even though they acknowledge that there is really inadequate evidence to suggest that care is equal between physicians and nurse practitioners. One of the strongest arguments for nurse practitioner-led care is the issue of patient access. We often hear this, that if nurse practitioners are not permitted independence, then patients will suffer because they will have delays in accessing care. Well, is that necessarily true? Well, the Lancet studied patient access and quality of care across the world, and they focused especially on developing nations. And what they found was that more people die every year worldwide due to poor quality health care compared to people who die because of a lack of access to care. And the reasons were because patients were not receiving correct diagnoses or because they were receiving the wrong information, which resulted in delays in care. And they found that even when efforts were made to improve the training of medical professionals in these areas by giving them refreshers or giving them additional education, that really did not seem to make a big difference in improving the quality. And instead, experts recommended that we return to a more foundational approach to providing medical care, and that rather than putting all these small clinics into rural areas where perhaps the clinicians were not as well trained, instead they recommended returning to the idea of having several large sort of meccas in bigger cities and then transporting patients to those areas where they would receive the higher quality of care. So that's something that in the United States we may want to take a look at and realize that we may be facing the same issue here. If patients are not receiving high quality care, then that access may not be making much of a difference. And the question is, how is the quality of care provided by nurse practitioners? Well, we know that when you ask nurses to self-assess their own competency, they actually do not rank themselves as being competent. And this was a study that was released that asked nurses of different training levels. You see the blue dot is nurses with an associate's degree, the yellow triangle with a bachelor's degree, and then the green triangle are nurse practitioners. So they're nurses with a master's level or greater. And you can see that even for master's level nurses, they do not rank themselves as competent in most of these clinical quality measures. So even nurses themselves are concerned about their competencies and their strength of their education and training. And without that feeling of competence and self-confidence, nurse practitioners and physician assistants as well tend to rely more on diagnostic testing to support their treatment plan. So compared with physicians, non-physician practitioners order more laboratory and radiology tests. They perform far more unnecessary skin biopsies. They prescribe more medication, including unnecessary antibiotics, psychotropic drugs, and opioids, and that they tend to refer more to specialists or have a poorer quality of referral to specialists. And I think this is going to become more concerning over time because, especially since 2010, with the increased funding to nurse practitioner training programs, we've seen a rapid increase in nursing programs that some people call diploma mills because they will accept any applicant. For example, there are 9 different nurse practitioner programs listed here that are up to 100% acceptance rate. So in other words, anyone that applies will be accepted. We see that, as we discussed, nurse practitioner training programs are accepting non-nurses directly into the program. They become a nurse and a nurse practitioner simultaneously. So these graduates may have never worked even a day as a nurse, and yet they may be able to practice independently in some states. Of course, we know that many nurse practitioner programs offer the education online. And here's an example of someone who received his nurse practitioner program through a direct entry program. He was a psychology major and then decided to attend a nurse practitioner program. And here is one of his social media posts that he was hired by a Minute Clinic and that he is, it says here, first day of work as an NP, orientation training for the next 2 weeks, and then I'm all on my own in my primary clinic. So a little concerning here that someone without any nursing experience gets a 2-week training and then is caring for patients independently. And of course, physician assistant programs are following the lead of nurse practitioners, and there are several online physician assistant training programs as well, and that may be something we'll see more of. And some of the nurse practitioner leaders have expressed concern about the increase in these diploma mills. Here's a social media post from a past president of the American Association of Nurse Practitioners who says that she thinks that these type of diploma mills are a huge liability, but that the AANP really is limited in what they can do about it. And again, social media is a place where criticisms and concerns about nurse practitioner training really abounds. There are a lot of different nurse practitioner help sites where there's posting about clinical concerns and questions. Things like the top, anyone have a book or resource they use for lab interpretation? I'm 3 weeks into seeing patients and realizing that I don't know what to do with abnormal labs. or a nurse practitioner that found out that they would be seeing pediatric patients, but they're worried and they're asking for helpful hints and they want to know how to prescribe antibiotics and medications to children. And then the final one, a 1-year primary care nurse practitioner that says that they really didn't get any experience in doing Pap tests and that they have a hard time finding the cervix. So these posts are so common that the current president of the AANP, Sophia Thomas, actually wrote an article about it where she advised nurse practitioner students and experienced nurse practitioners not to go online to discuss these concerns, saying that anti-nurse practitioner trolls, she called them, are seeking out these posts and using them to criticize nurse practitioner independence. So what she says instead, that rather than posting, that you should use a private message, or alternatively, it says, take a minute to refer to your evidence-based clinical references, which is a good idea, or do a quick online search. Your answer can be found there. Of course, critics would argue that, maybe if nurse practitioners were getting the kind of education that they needed in their programs, that they would not turn to social media to the same extent. The biggest problem that I see is that patients don't know the difference between nurse practitioners, physician assistants, and physicians, and part of that has been a deliberate effort on behalf of advocates for non-physicians to blur the differences. It's confusing. There are 183 different nursing certifications, and often nurse practitioners have a long string of alphabet soup behind their name that can be hard to tell what type of a practitioner you're dealing with. There has been a rapid increase in doctorate level degrees, the doctor-nurse degree, and even a doctorate for physician assistants now. On the right, I have a headline here from a newspaper that said that a University of Lynchburg medical student skipped graduation to treat COVID-19 patients, and then they say that he is a doctor, graduated from a Doctor of Medical Science program. So they're misleading patients in two ways. They call him a medical student, he's a physician assistant student, and they call him a doctor. The Doctor of Medical Science is a physician assistant doctorate degree. And then, of course, there's the appropriation of terms like the use of board certified, residency, and fellowship, which were typically reserved for physicians. Now there are nurse anesthetists are asking to be called nurse anesthesiologists. So there's all sorts of blurring of the distinction between the practices of medicine and the practice of nursing and physician assistant studies. There's been a direct marketing campaign to patients to try to encourage patients to seek out care from non-physicians and to explain to patients that these professionals are just the same or even sometimes better. The AANP's campaign is called We Choose NPs. The PA's is called Your PA Can Handle It, or Your PA Can. And in fact, I'll point out that physician assistants have tried to change their name. They don't want to be called physician assistants anymore because they don't like the word assistant. Some of them, the new American Association of Physician Assistants is now called the American Association of PAs, and so they're trying to take away that term assistant so that they can be seen as more autonomous. And of course, a nurse practitioner or physician assistant can call themselves a specialist really in any field. Of course, we know physicians cannot do this. You have to complete a residency and take a board exam before you can call yourself a specialist. But here you see some postings. Here's a nurse practitioner that's just accepted a job with nephrology and oncology. There's a nurse practitioner who calls herself a rheumatologist because she took a number of courses from the American College of Rheumatology. If I, as a family physician, took some rheumatology courses, I could never self-identify as a rheumatologist. And then here is a nurse practitioner who is a mental health nurse practitioner calling herself a psychiatrist. Patients also, they don't know the difference, but they also don't know that nurse practitioners are not held to the same standard of care in a medical malpractice case. This has been shown numerous times in case law, in which the jury has been instructed that the standard of care for a nurse practitioner must not be measured by the standard of care for a physician. And in fact, physicians are often not permitted to testify against nurse practitioners. All of this is really not to undermine the importance of nurses. Nurses are so critical to our healthcare system, and it's actually, by pointing out these flaws with the nurse practitioner program, it's really so that we can help support and increase our nurses, because there's already a bedside nursing shortage. And when you ask, why do we have such a shortage of nurses, you usually hear, well, there's, the aging of the population and the aging of the workforce. But what you rarely hear is the problem of nurse practitioner training, because it has actually reduced the number of registered nurses by 80,000, and that's expected only to increase. When the Institute of Medicine called for an increase in doctorates and in bachelors and increasing nurse practitioners, they really said nothing about efforts to expand the number of bedside nurses, and that's so important to our healthcare system. And we need nurses, and we also need physicians. And I showed you the graphs of the rapid increase in nurse practitioners and physician assistants. So here's a comparison with what medical school graduates look like. It's relatively flat. There's been a 20% increase in medical school graduates between 2010 and 2020, but really the bottleneck, although there has been an increase in medical schools and graduates, there really hasn't been a meaningful increase in residency programs, and that has to do with the freezing of funding to residency programs back in 1997, which has never been touched politically in all of these years. And we know that teams work, but they need a leader. And it's really concerning especially when I see medical students and residents not receiving the important message that they need to lead the medical team. In fact, we're seeing posts on social media from residents. Here's one in a family medicine program, and it says that they're going to be supervised in their psychiatry rotation by only a nurse practitioner. And so this is not right. Physicians need to be trained by other physicians. And it's even more concerning to see there was a leaked document by a Stanford medical school interviewer who reported that they were told that they needed to ask the candidates this question: how would you respond to a patient who demands the service of a medical doctor rather than an allied health professional in their health care? And the correct answer, according to this interviewer, was that candidates were supposed to be able to explain that allied health professionals were important members of the healthcare team, and that sometimes they could provide even better aspects of care. So the bottom line is that medical students are being selected and indoctrinated into a new type of program that says we're all the same, and that doctors are no better or worse than any other member of the medical team. And the truth is that the person with the highest amount of training and education needs to be the person that's in charge, so that patients can get the best quality of care. The truth is that many nurses, nurse practitioners, and physicians are concerned about what they're seeing, but many are afraid to speak out. Nurses and nurse practitioners are really quite afraid because they face repercussions. Here is a slide from the American Association of Nurse Practitioners meeting in 2019, and at their final meeting of the session, there was the speaker, Margaret Fitzgerald, a nurse practitioner and advocate, and she advised nurse practitioners to stay quiet if they opposed full practice authority. And here in this picture you see the zippered mouthed smiley face saying the strongest NP voice is silent. So nurse practitioners are being advised not to speak out. And in fact, the AANP on their website, they have a reporting link where if you see criticisms or concerns about nurse practitioners and full practice authority, then you're encouraged to report them. And the website says that people that make reports will be protected, their anonymity will be protected. So there's definitely an effort to thwart any voices of opposition. And of course, physicians, many are afraid to speak out because they'll be fired or they'll face serious repercussions. And doctors are being fired and being replaced by nurse practitioners across the country. And here are just a few headlines. We've really just hit the tip of the iceberg in this important issue. So if you are interested in learning more, I encourage you to get more information at our website, physiciansforpatientprotection.org. Please join us, especially physicians. And please read my book, co-written with Naran Al-Ajba, that is coming soon from Universal Publishers, which contains this information and much more about what we can do to ensure that all patients receive access to high-quality health care. Thank you, and please feel free to contact me if you have any questions, RebeccaBernard.com.